Okay, hope everybody's made it into the most important session of the meeting. Okay, so DCB for bifurcations should be all the rage. I'm expecting all the seats to be taken. So we have a pretty stellar panel, apart from me, who all know a lot about DCBs. We've got quite a few talks to get through, and hopefully quite a lot of audience discussion as well. So let's first up invite Eun-Seok Shin to come and talk about angiographic change in side branch ostia. Thanks.
Okay. Thank you for the invitation to present at the EBC 2024 meeting. Okay, so unlike metal stenting, DCB does not produce carina shift. Instead, after drug-coated balloon treatment in the main vessel, an increase in side branch ostium occurred. So this patient has a true bifurcation lesion in the RAD. This treatment was performed only on the main vessel. However, the side branch ostium slightly enlarged. So when observed with OCT, it is evident that although DCB treatment was performed only on the main vessel, the side branch ostium area also increased. On the contrary, this region was confined to the side branch ostium 001 type. DCB treatment was performed from the RAD to the diagonal branch. The follow was good. So when confirmed by IBUS, the lumen of the side branch was enlarged. The lower limb of the confluence in the main vessel, which is prone to compromise if we put a stent. However, it showed increased lumen area. It measured 6.7 square millimeter at baseline and 8.2 square millimeter after the procedure and 9.0 square millimeter at follow-up. So to confirm this phenomenon, we measured the side branch OCR area in bifurcation lesions using OCT. All lesions were increased with the DCB exclusively for the main vessel. Lumen area of the main vessel generally increased, and the side branch ostium also, the area significantly increased with expanding by 76%. So at follow-up in this case, the dissection flap in the main vessel completely healed, and the side branch ostium enlarged. So this also be verified in 3D reconstructed images. With this background, we aim to evaluate using angiography to determine whether this phenomenon is unique to DCB treatment. Among patients in the DCB registry, 132 patients with de novo bifurcation lesions and follow coronary angiograph data were enrolled. Bifurcation lesions with the main vessel 3 millimeter or over and the side branch 2.0 or over were selected. However, cases with the severe side branch stenosis requiring a procedure and PCI were all excluded. According to the DCB consensus guideline, the main vessel was treated with either DCB or DS. All DCBs used was paclitaxel with eopromide. For analysis, the bifurcation region was divided into 7 points as follows. The endpoint is side branch OCR, minimal lumen diameter and diameter stenosis. And we also analyzed the upper limb and lower limb of confluence in the main vessel. And the other parameters is for all main vessel. The delta value of minimal lumen diameter and diameter stenosis were defined as subtracting follow-up from the pre-procedure. So the minus value indicates an increased diameter. So there was no significant difference among the three groups, including bifurcation type is also incomparable. Here is the result of the study. The diameter stenosis of the side branch ostium was around 30%. The largest increase of side branch ostium was observed in the DCB group, with an increase of 0.16 millimeter. In contrast, the DES group showed a decrease of 0.5 millimeter, and the untreated group, medication group, is decrease of 0.08 millimeter. The minimal lumen diameter in the main vessel showed an increase in both the DCB and DES groups. So there was no change in the minimal lumen diameter and diameter stenosis in the untreated medication group. However, in the DES group, side branch OCR minimal lumen diameter decreased and the diameter stenosis increased. However, in contrast, in the DCB group, side branch ostium did not compromise. Late lumen loss of the side branch ostium was similar in the DCB and medication group, but it was higher in the DES group. This is a 61-year-old man and stable angina. He had a positive treadmill test. The ST segment is sustained, the depression is sustained until recovery pace. It is a high risk. Left main was a true bifurcation lesion, like this. Lesion preparation was performed with a pre-dilation balloon sized to match the reference vessel using 3.5 millimeter up to 14 atmosphere. The results were satisfactory. The flow was normal in both the complex and RAD. And left main to proximal RAD was treated with a paclitaxel coated balloon, the same size as the pre-dilation balloon, 3.5 millimeter. It was also successful with normal flow in both RAD and circumflex artery. We didn't touch it for the circumflex ostium. This is a follow-up coronary angiogram. We performed 6 months later. As per the study protocol, the symptom is free. The left main bifurcation remained well patent, like this. So compared to the baseline, the MLD of main vessel increased by 2 millimeter and circumflex ostium increased by approximately 0.1 millimeter. This patient has been asymptomatic for the past 6 years. So in summary, the side branch ostium enlarged only in the group where the main vessel was treated with a drug-coated balloon. In the DS group, it becomes smaller, and there was no change in the untreated group. So we found that treating the main vessel with the DCB can reduce the risk of side branch OCR compromise. So in conclusion, paclitaxel-coated balloon treatment applied exclusively to the main vessel in the de novo bifurcation region has demonstrated superior angiographic outcome in the side branch ostium compared to the drug-eluting stent implantation. Thank you for your attention.
And I think this is a very, very important information. You know, about 10 years ago, our group, together with Bruno's group, published the positive remodeling. And we have been often discussing, is this a vessel size increase or is this a plaque regression? It's probably both, but you showed definitely with the side branch ostium increasing that the whole vessel gets larger. And this has also been shown by pericardial application even of paclitaxel. So I think it's very important to go into the mechanism of this treatment. Thank you very much.
Okay, thank you.
Yes.
Yeah, just a question. In the first case you showed there was an obvious dissection there. What criteria do you use to say it's a stable dissection and I don't need to do anything? So in other words, do you look at sort of the circumference where the dissection is, the flow? What do you look at to say, I'm happy to leave it?
Yes, and you know, and to increase the lumen area, that means and increase the flow, we need to make the dissection. No dissection, no luminal gain. However, in the flow limit dissection is we have to fix the dissection like that. So we need a metal scaffold. However, in non-flow limiting dissection, that's okay. In CTO lesion, it's just if the residual diameter stenosis is over 90%, the flow is good, it's okay. However, in the non-CTO lesion, for the future outcome, we need follow the consensus guideline. The residual diameter stenosis is less than 30% and flow is good, that's okay, even though the dissection is type D or E.
I have just one comment according to the dissection that we are trying before to stent it maybe. But if it's not flow limited dissection, we had a patient 3 years ago, we did it in a fraction. We make a PCI left main to LAD with a circular dissection to all LAD without the branches, but it was flowless to the apex of the heart. After 3 years, we did it a new angio 1 week ago, and it was perfectly healed dissection without DCB. Without DCB. So not leaving nothing behind is the best solution, even without DCB in some cases, if there is no flow limited dissection.
I mean, even Andreas Grünzig's group showed that if you have dissection, you have a better lumen and a better outcome.
Okay, great. Thank
Okay.
you ever so much. Really
Thank
great
you.
presentation, actually. Over to Bruno.
Yeah, thank you very much for the invitation. It's a great pleasure that we as the DCB guys are allowed to be part of EBC. Really great, thank you. I'm not sure who gave me this talk about 001 bifurcations. We know from all the stent trials that 001 bifurcation lesions have the worst outcome. Many of those patients are treated with 2 stent techniques, despite the fact that the main vessel is not affected. This seems to have some change over the years, but there's still need for treating also the main vessel in some of the cases. Shortly, what are the different scenarios for DCB in bifurcations? We have this blended or hybrid approach with stenting the main branch, treatment of the side branch with DCB. Then we have the puristic approach, where we try to avoid any stenting in the bifurcations using DCB in both branches. And the simplest one is what Professor Shin showed, using the DCB only in the main branch if there's only ostial disease of the side branch. This is again the data you have seen before, and this is really an easy application. However, I think it's more for the smaller side branch and not for the bigger side branches. These are examples for the special case of ostial circ lesions from our colleagues from Japan again, doing orbital atherectomy first and then using DCB, which is really unique and not available in our countries here. But I think this is an interesting approach, and here you see some follow-up pictures. Unfortunately, we do not have lots of data for 001 bifurcations. This is a trial more than 10 years ago published by Rathore and colleagues from Spain. And they randomized the side branch to DCB or uncoated balloon angioplasty, and what they found was that the late lumen loss in the DCB group was significantly lower than in the uncoated balloon group. However, this was not a trial only focused on the side branch. It was only included stenting in the main branch. What we did under the guidance of Franz was the PEPCAT-Bif trial. In this study, we focused on the side branch and randomized to DCB or uncoated balloon angioplasty, 32 patients in each group. And the primary finding was that late lumen loss in the side branch was significantly lower with DCB compared to uncoated balloon angioplasty, and also the binary restenosis rate was significantly lower. However, this trial was not powered for clinical endpoints, so this is also a mechanistic description that we can reduce the restenosis rate in the side branch with DCB. This is a meta-analysis from Simon's group of the data available for the side branch treatment, and here you can see that there's an angiographic benefit when using a DCB instead of an uncoated balloon in the side branch. The question is, does this have any clinical relevance? This is a paper from a group in China published a few years ago. They report a reduction in MACE when using DCB for the treatment of the side branch. However, this is not a randomized study. There's also a meta-analysis looking from different trials, non-randomized trials included, on the impact of drug-coated balloons on the treatment of side branches, and also they report a benefit in clinical events. But to be honest, I'm not really convinced that we can see this big difference in clinical events when we are focusing on the side branch. Another important investigation, in my opinion, here comes from Japan again. They looked at the impact of late lumen loss on the clinical outcomes if the side branch is treated by a drug-coated balloon, always, depending if there's lumen enlargement or not. And that's very interesting. If you look, for example, at the binary restenosis rate in the last line, then you can see that if there is lumen enlargement over time, then there is no restenosis. If you have not this effect of late lumen enlargement, then you have to deal with restenosis and possibly TLRs. And this comes to this concept which we discussed before. We have to be aggressive when treating lesions with DCB. We see with paclitaxel-coated balloons that the more aggressive you are, the more dissection you create, the lower the late lumen loss is. And I think that's very important, that we need an adequate sizing with a 1-to-1 ratio when treating also bifurcations with DCB. This is an example from this PEPCAT-Bif trial we published. This was 010 bifurcation. And unfortunately, also with DCB treatment or with lesion preparation, you can have carina shift. This was the case here. So we needed a 2 DCB strategy for both branches. And you can see that the final result is not really good. There's haziness in this lesion. This means dissection. The lumen is not perfect. But we see the healing of the dissections at 6 months and an improvement of the lumen. And interestingly, in this case, we looked with IVUS at a plaque volume. And in this treated area, the plaque volume was more than 50% lower than in the angiographic healthy areas before and after it. And this is one of the findings we have. We have an increase in total vessel area, what has been discussed, but we see also some kind of plaque regression by this local treatment. So, and this is already my conclusion. We know from several smaller trials that DCB reduce late lumen loss and restenosis and possibly TLR in the side branch. However, it is unclear whether this can actually lead to reduction in hard clinical endpoints. The advantage of DCB in bifurcation is the simplification of the procedure, for sure. But I think an effect on hard clinical endpoints will only be seen if we also apply this concept in the main branch. Thank you very much.
Okay, let's open that up for questions. Bruno, perhaps you could explain to us what do you think is the mechanism then of the plaque regression when you use DCBs? What's actually happening that influences that?
So we know from experimental data that paclitaxel has some anti-inflammatory effect in the plaque, and this may contribute to some change in the structure and maybe some, at the end of the day, a reduction in volume. This is one mechanism, but the more important mechanism is the improvement of the total vessel when looking at this lumen enlargement. So plaque regression is a nice to have, but not the most important factor, I think.
Bruno, it's a great talk. Is this working? Yeah. It's a practical question. If you have to do a 001 bifurcation, presumably you've already tried to manage them optimally medically, but if you're forced into doing that angioplasty where you don't want to jeopardize the main branch, any particular tips and tricks on how to do the PCI so you're not ending up in a 1 or 2 stent situation?
So I meanwhile prefer starting with specialty balloons, cutting or scoring balloon. Why? Because at least at low calcification level, you have a better initial lumen gain. With scoring balloons, you have less dissection. You have dissection, but you have more controlled dissection. And I think that's key, and it's a one-to-one sizing. I know we discussed this several times, if we should go for smaller sizes or not, but meanwhile I think it's important to go one-to-one.
Thank you for your presentation. So practical question, when you have restenosis, bifurcation lesion like Eccleshall technique, and then you have the main vessel is restenosed as well as the side branch, then you need 2 drug balloons for both. How can you do that? Is it one by one, or you can do kissing with both of them? What is the, I know it is not published yet, but what do you think?
You mean for in-stent restenosis?
But the main vessel and its side branch both are having restenosis, and then you need balloon for each one.
In-stent?
In-stent.
In-stent, yes. So for DCB, the basic rule is don't do kissing DCB. This makes no sense because you lose track with the first one when positioning the second one. And you have not full contact to the vessel wall with the balloons because they kiss each other, so that this makes no sense. This means this is a sequential approach. I usually start, independent if it's ISR or it's de novo, prepping the main branch, then doing lesion preparation of the side branch, applying the drug in the side branch, applying the drug in the main branch. So that's the typical way. And if you then have carina shift or whatever, then you can do kissing with conventional balloons to have the mechanical optimization.
No. Congratulations for your presentation. Do you think that the drug-eluting balloon is the choice treatment for 001 lesion? Do you think it's better than inverted provisional with the stent? Oh.
I mean, if I have only this problem with the proximal or the ostium of the side branch, I think it makes sense not to implant a stent to avoid the carina shift and go with the balloon after lesion preparation. Yes.
Do you think that this two type of treatment deserve a randomized trial?
Yes, I think we will hear about...
No, for 001.
001. I mean, we did this PEPCAD-Bif trial, which was a mechanistic trial, and we see that this makes angiographically against Proba, it's better. I think if you look against drug-eluting stent, there will be no big difference in angiographic outcomes, and it's hard to show a clinical benefit if you treat small side branches. I think that's really difficult to show.
Okay, Shostakovich is growing louder, so last question.
Just one question about the treatment with the antiplatelet therapy after the DCB. Do you prefer only antiplatelet, or you can add anticoagulant like rivaroxaban 2.5 milligrams if it's needed? This is my question, actually.
So if the patient has an indication for anticoagulation, then...
No, without indication for anticoagulation, only for after the DCB ballooning?
I don't think it's necessary. I mean, what you mean, I think it's that we are talking about small thrombus formations within the dissections, which is typical. But what we know from neuroimaging trials and from the clinical data we have is that the DAPT is enough to control this problem.
Great. Thank you very much. Great talk. Thanks, Bruno. So we're now going to move to Bernardo Cortese, who can't be with us, but is with us in spirit, if not in body, in the form of Zoom, I think. So,
yeah. Thanks, Dave.
Very nice.
Can you hear me?
We can.
All right. Thank you. Thank you again, guys, for the invitation. Yeah. Also this year, I can make it, but hopefully the next one I will be more lucky to be there. Yeah, you're asking me about this sub-analysis of the EASTBOURNE. Actually, I have to say that since we are at EBC, which is a quite non-formal meeting, I decided to change it a little bit. It's not very fascinating to discuss about sub-analysis of a big registry. So my main goal today is to give you my take on the current status of bifurcation managed by DCB, and which is the future, in my opinion. And I have to say that I'm pretty much on the same page of what Bruno just told us. First of all, we have a need, and the need is coming from, many studies and several meta-analyses. I just picked up one managed by my good friend Fernando Alfonso, which is the last author of this meta-analysis, which is showing that still with bifurcation on a mid to long-term follow-up at 3 years, we have a clinical need. Because either we use 2 stents or just 1 stent with a provisional approach to the side branch, we have quite a lot of MACE. And here, from these studies, the complex bifurcations that we have to manage were excluded. On the other hand, we have a lot of data also with intravascular imaging, which are showing how the management of the side branch with a drug-coated balloon, and we have a lot of data with paclitaxel, is very good. Is very good. The effect of paclitaxel on the side branch is showing how it is protected, and late lumen loss is often negative if we go and analyze angiographic data. We have meta-analysis also for this. We know that the late lumen loss is negative, and it is much better as compared to a POBA for the side branch. And we know that, again, for the side branch, the TLR rate is lower. Okay, so we have the EASTBOURNE study. EASTBOURNE study is a prospective study, a large one, more than 2,000 patients enrolled prospectively in Europe and in Asia. With a Magic Touch sirolimus-coated balloon, primary endpoint is TLR at 1 year. We have published last year the 1-year follow-up, and this year in your intervention, the 2-year follow-up. I'm not gonna go deeper into this study. We have a pre-specified bifurcation study within the EASTBOURNE, where all Medina lesions were allowed according to the preferences of the physicians. All the events have been CEC adjudicated. We have 1-year follow-up available for this sub-analysis, but these are really exploratory, not definitive findings. So about the population that we have enrolled, we have 212 lesions treated with a sirolimus-coated balloon, with most of them with a side branch, but there is a good representation of almost all of the types of Medina classification. I have to say that these patients have been treated between 2016 and 2019, so there is a quite conservative approach. With 92% of the cases of the bifurcation, there was a stent implanted in the main branch, and a DCB only in the side branch, with a full DCB revascularization only in 8% of the cases. So this is the population. We did a comparison between de novo and bifurcation. No specific mentions about important differences. Also technically, there is more predilatation accuracy for the bifurcation subgroup, and also the diameter of the balloon used for predilatation is larger than the de novo, which is representing mostly small vessel disease setting, I have to say. So this is the outcome, which has been published this year of this bifurcation, 212 lesions, 194 patients. And there is a comparison to the de novo lesion setting with no significant differences for the primary endpoint of TLR, 4.2% at 1 year, and a MACE 8.8%, no significantly different to the de novo lesion population. We have several limitations. These are only exploratory findings, no protocol mandated. It's just a registry. We have no information specifically on the technical data for how main vessel or side branch were treated, how DCB were applied. Some of them, unfortunately, were applied with a kissing balloon, which is something that now, today, we discourage, and I agree with Bruno on that. And we have few information about the technique, and we don't have core lab. So several limitations for this study with exploratory findings. But as I said, I would like to put this into a context of the current management of bifurcation, and which can be the future lines of research for this. So far we have small studies, mechanistic studies with a good TLR, quite different according to the studies. We go from 15.4% on a study, a Babylon study, which did not go well, talking about the side branch now, to 2% of the depth side. So there is a quite big range of variability for the TLR for the side branch. So which are the main limitations of the current studies for DCB in the bifurcation? We have few patients enrolled so far with debatable designs. We can see everything in these studies. If you go and pick all of them, you can see everything. Also because there is a lot of heterogeneity for bifurcation management. Results are a little bit controversial. We have good results for sure for the side branch, but we don't have many results for hard clinical endpoint. Luckily, we have good studies on the go. These are the studies that I picked yesterday from clinicaltrials.gov. This was my download of randomized clinical trials ongoing or, hopefully about to start enrolling patients. We have this DCB for China, Picoletto 5 from our group, BJ DCB for China, Stent-Free Romania, Magic Touch, it's a study mainly enrolling patients in the Netherlands. And then we have the EBC study that David will present you later. So which are my takes for the future trials on DCB? First of all, we should provide randomized clinical trial comparing provisional stenting and dual stenting with hard endpoint, but with an adequate sample size, which should be studied very well, and long-term follow-up. This is one area. The other big area that we need to address are randomized clinical trials again with provisional or dual stenting versus full DCB. Okay, we want to see how the full DCB in the main vessel, DCB in the side branch, two separate inflations are going with long-term follow-up versus standard of care. I'm presenting you the couple of slides of Picoletto 5 study that is on a startup phases. Wojciech is the PI for this study. We are enrolling patients, no left main, with 111, 101, 011, 001 Medina classification, big vessels. After lesion preparation, we are randomizing patients 1:1:1 to EBC-like, so provisional stenting, hopefully, to full sirolimus coated balloon with a sequential inflation, to full paclitaxel coated balloon with sequential inflation. And we will analyze the 9-month follow-up as a CT scan, a functional assessment, if there is differences in the main vessel and in the side branch. That's it, and thank you for your attention. I'm here for you to reply to any criticism or question.
Great presentation. Any questions for Bernardo? Everyone's gone quiet. That was such a good presentation.
Yeah. No. Please, ask me something.
So what stage are you at with the Picoletto 5, Bernardo? I mean, we've discussed this a little bit, but...
Yeah. So we have selected the centers. We have selected the countries. It will be a European study. We have some findings. I have to admit that it's quite difficult to run a good quality study with core lab assessment, CEC, DSMB, with funding. We are an independent foundation, so that is not that easy. So we are still collecting findings, but we have a very motivated group of physicians and PIs led by Wojciech. So this is our current status. Hopefully, we can enroll the first patients in Q1 25.
Great, thank you. So, question for you from the floor.
Hello, Bernardo. This is Hema de Rathore, your friend.
Hi, my friend.
This is we are talking continuously about DCB versus DES based on angiographic appearance or whatever. But what about intravascular imaging providing insights to finally make a selection of when DCB could be better than DES? Because we are relying on in the lumens and the angio and the angulation, but maybe it's mechanistic studies using imaging, OCT or IVUS, I don't know, could be better to make a proper selection of this type of bifurcation is better served with DES or better served with DCB or combination, because we are just treating all of them as the same, but we know for intravascular imaging that a 001 can be just a plaque in the ostium, or it could be a plaque extending into the main vessel. And because positive remodeling, you don't see the stenosis in the main vessel, but there is a lot of plaque, and then the outcomes are quite different. What do you think about this, Bernardo?
Yeah, I want to be very honest, and maybe I can be a little bit too direct. I fully agree with you. In a complex or, I wouldn't say that we should use imaging in 100% of bifurcation, but I would say 80% of them should be used. I think that you are depicting what we should do now and what we are currently doing now, because we believe that DCB should be used in the vast majority of bifurcation. So intravascular imaging, decide according to your results, according to how is the result after predilatation, when to use a stent, if to use a stent. We are designing clinical trials just to convince the other people to use DCB for the bifurcation. So this is why we are designing this study. I'm not designing these studies for us. We are already convinced about DCB.
Okay, super. That's great. Thanks ever so much, Bernardo. We're going to move on now to the next talk, which is Xiaoliang Chen. Now, I haven't seen Xiaoliang here, so I'm going to guess that he's also on. Oh, you don't have him? Oh, no. Okay, well, we've made up some time then. What happened to Xiaoliang? Okay, never mind. You don't have him? He hasn't made contact? Okay. Okay, never mind. Never mind. We will hear more, no doubt, about his study, later in the meeting. Okay, well, let's move on then. Yiannis Chatzizisis is here. Is Yiannis here? No, that's good. That's bad now. That makes it difficult to chair this session. Where's Yiannis? He must be in the other session. He's here. I've seen him. Yeah, somebody go and get him. Somebody go and tell Yiannis he's on. Meanwhile, whilst we're waiting for Yiannis, any further comments? I mean, Bernardo's gone now, but I mean, any more comments? Anything of insight from the EASTBOURNE registry or from the plans for his upcoming studies?
I mean, one thing we can discuss, I realized that the difference between the Picoletter 5 design and the EBC design is that randomization occurs in the Picoletter 5 after lesion preparation. And I think we are planning more a strategy trial defining. So Bernardo, what do you think, what are the pros and cons to randomize before or after lesion preparation?
Yeah, this is also the big difference between the solution study and the Transform 2. I still believe that we don't have to be too much, to have decided which is the best treatment for our patients up front. So my final decision if to use a DCB in any lesion setting, also for ISR, is taken after lesion preparation. So I think that this type of trials are reflecting more what we should do to provide the best treatment to our patients. So they are more, real-world studies. On the other hand, if we randomize patients up front, the risk is that there is a slightly higher bailout stenting rate. So this is another fact. That the solution study, Simon presented very interesting data, I don't remember at which meeting, showing that according to the experience of the physician, at the beginning of the experience of the physician, bailout stenting was quite high, and after few months of experience with DCB, it came down. So yeah, this is my comment on if to predilate before or after randomization.
Hi, Bernardo. It's Simon. So I think it's actually quite important that we have both types of studies, because there are some people out there that want to know the difference between whether to use a DCB or a stent when they're finishing their angioplasty, whereas there are other people that want to know whether the whole strategy up front is the right thing to do or not. And I think both are important, and for different groups of people, you will be able to answer the question. So hopefully between the two different types of trials, we will get as much coverage as possible. So I think both is a good idea, personally.
I agree.
Okay.
I agree with you.
Perfect.
Yeah.
That's an excellent answer. Thank you so much. So now Yiannis is here. Yiannis is going to talk to us about a new paradigm for the treatment of in-stent restenosis.
Hello, everybody. Very, very thrilled to be here and among friends. Drug-coated balloon, a little bit more sophistication, if you want, with simulations on how we can plan these procedures. These are my disclosures. Background, we know very well that 10% of our PCIs, more or less, are intended for in-stent restenosis. Everything starts with a mechanical stimulus that triggers a biological response, neoatherosclerosis or NIH, and imaging is very, very important to understand what's going on. It's classified as 2A in the US and American and European guidelines for imaging of ISR. Treatment options, traditionally another second or third DS, brachytherapy, not very popular nowadays, bypass, bailout, but in Europe and now in the US as well, we have this option of drug-coated balloons. That's the algorithm. First, we identify the mechanism, then plaque modification, then again imaging to confirm that we are ready to receive the therapy with the balloon, the DCB, and then final angio assessment. I'm going to show you two cases which illustrate our approach. Actually, these were among the first commercial cases in the US. First case, 73-year-old woman with symptoms. She has exhausted the surgical and interventional approaches. She has been having bypass, both grafts failed, and multiple PCIs to the RCA. SPECT shows that she has ischemia in the inferior wall, the RCA territory. She has exhausted all the medical therapy. She keeps having pain. That's the baseline RCA. You see here there's significant ISR within 2 layers of stents, proximal and distal, as you see there. So what we do at this point, we 3D reconstruct this using angiography and OCT. That's the digital twin. You take the artery from the body into the computer. Then you see the whole mapping of the area. Black line is the old stent, double stents, and the red is the lumen area. And you see here all the gray zone is the NIH with these two sites which have significant restenosis, 1.44 and 1.27 MLA on both sides. That's the stiffness mapping. So you see here, whatever is essentially green is the stiffness tissue. So I'm sorry, the NIH tissue, which is quite stiff, fibrotic material. And using this wall, simulating the pre-dilatation computationally with a 3030 NC balloon in a patient-specific environment, inflated high atmospheres. And what you see here, that unfortunately, this balloon doesn't expand well on those two restenotic sites. So what we do next here, this informs that we need to do something more before we go there and prepare the lesion with some debulking, pre-dilate, possibly with a cutting balloon, to which the simulation helps us to size it to the right size. Of course, NC balloon, then confirm the result, the lesion preparation with IVUS or OCT, and then apply the DCB therapy. So that's the planning, informed, guided by the simulation. And that's what we achieved, the lumen gain after the simulation-guided informed lesion preparation. That's now after the cutting balloon and, of course, the laser. And you see here now the lumen gain. As you can see, this is the old lumen. And now this is the lumen gain. We gained some lumen, which restored the area from 1.4 to 3.4 proximally, and then from 1.27 to 2.5 distally. And that's hemodynamic assessment by FFR and CFD. You see on the top, pressure drop across the proximal stenosis. 0.75 is the angiographic FFR, which is restored to 0.93 after the lesion preparation. And of course, CFD showing the flow acceleration on two sides, proximally and distally, which is restored homogeneously after the lesion preparation, adequate preparation. Now, after this approach, we're ready to go ahead and deliver the therapy with DCB, as we did here, a 3030 balloon, well expanded nicely to cover both proximal and distal stenosis. That's the final angiogram, all good. Patient goes home. 3 months later, she's pain-free, resumed her clinical activity. She's happy. But now we have some restenosis, a little bit more distal to the proximal restenosis. And you see here, that's a very interesting situation. That's the angiogram. That's the 3D reconstruction, again, based on the OCT at 3 months. And now what we see here, we see that we have a new stent restenosis, just distally to the proximal restenosis. The proximal restenosis has essentially positive remodeling, looks better now. And distal restenosis looks slightly worse. So you see all kinds of responses here. We battle with biology. It's not like black or white, and that's the new stent restenosis. However, the patient is feeling fine. She's doing well. With DCB, we bought some time, and maybe we have open therapies for the future or repeat another DCB. Case 2, a man now, 74, with active refractory chest pain to medical therapy, maximal medical therapy, all kinds of risk factors. He has in-stent stenosis of an LED and circumflex stent. We fixed the LED already, and now we focus on the circumflex. You see here the proximal site, which is a de novo fibrocalcific stenosis, and also distally we have an in-stent stenosis, fibrotic calcific material, neoatherosclerosis within 1 layer of stent. So both types, both phenotypes of atherosclerosis here, stent stenosis distally, de novo lesion proximally. We do a 3D reconstruction, again using here IVUS and angio, digital twin essentially, generation. You see the proximal and distal stenosis, proximal stenosis, distal stenosis, replicated in the computer very faithfully. And you see the mapping of the areas, and you get to see here the NIH area, the neoatherosclerosis area between in the distal part. And of course, you see by IVUS, proximal fibrocalcific plaque, 30 MLA, and then distal restenosis, stent restenosis with an MLA of 1.52. What we do now, we use this information, first of all, to assess the hemodynamics. You see the flow acceleration with red in the proximal stenosis, de novo stenosis, and also distally in the long in-stent stenosis. And also, we assign patient-specific materials. You see proximally, it is based on this spectrum here. It's on the red side, pretty calcified, pretty stiff, if you want. And then distally in the stent stenosis, it's quite stiff as well because it's full of fibrotic material within the stent. And now we see how the vessel would respond using a computational simulation of an NC balloon distally and a stent proximally. Again, it's all simulation plan to see what we would expect if we go in the real case. So you see distally, the balloon in high pressures, the NC balloon expands but not adequately, which means that the lesion is quite stiff, needs some more preparation before we go ahead and do the DCB. And then proximally, you see how the stent would respond. You see we expand the stent here. It's a patient-specific stent, and it expands pretty well the lesion. So with that, we now have an informed planning of the distal restenosis with DCB approach, with a debulking with a laser, pre-dilatation on high atmospheres with cutting NC balloon, and then confirmation with imaging. Again, the sizing of the balloons is guided by the simulation, and of course, a 30 DCB balloon at 6 atmospheres for 3 minutes to let the drug go there should be okay. And then proximally, we'll go ahead with the de novo stenosis with a DES, and that's the sizing of the pre-dilatation balloons and the stent. So with this approach, essentially, we ended up using simulations informed, powered by imaging to help us understand the nature of the problem and size and plan our approach appropriately. DCB PCI is durable, superior to angioplasty, avoids several layers of metal, keeps the future treatment options open, and then, of course, shorter depth. And the imaging-powered stent simulations can identify the mechanism of ISR, can help us predict the need for advanced lesion preparation, like laser or rotational atherectomy or whatever. And, of course, it helps immensely with precise sizing and positioning of the therapy, whether this is DCB or a stent. A big thank you to the funding resources from federal industry and philanthropy areas, and, of course, to my group, the engineers, the medical doctors, and thank you all for your attention.
Great, lovely computations. I'm not sure I quite understood how you do it though. Presumably this isn't available sort of to you as you do the procedure. This must be something that you take the images, you then take them for computational analysis, work out what you think the artery will respond to, and then the patient comes back for the treatment. Is that
what I show you today is 2 sessions. One is the baseline acquisition of the IVUS or OCT and angiography, and then simulation, digital twin, simulation, planning, and then the second session is the actual delivery of therapy. The good news is that we have at this point the computer power to implement this concept at the point of care in real time. I think getting there.
So that would be amazing. So
Yes.
you think you're getting to the point where
Yes.
you could take the angiographic images and, as it were, online
in real time at the point
in
of
real
care
time.
to make the decision
Okay.
right away,
Okay.
because we are all interventional cardiologists, or most of us, and nobody is pleased with the idea of taking the patient off the table and go back. So we want to deliver impactful care at the point of care in a very precise and very patient-specific way.
Questions for Yiannis? Yes. At the back there.
Thank you very much for your presentation. I have one question. It's on the technical side. How do you predict the result of the angioplasties based on previous data from interventions with IVUS and OCT, or is it tables on the bench side tests? How is it done?
Yeah, that's a very good point. We have built the computational simulation platform and validated this against real clinical data. And now that we have the computational model, which is faithful against the reality, we can use it prospectively to see the response of each individual coronary artery to any stent, any balloon, any therapy.
Yiannis,
Yes.
fantastic presentation. Congratulations again. Yeah, and I was going to dovetail onto that, because really the secret sauce of this is creating the database to then predict it, right? So do you use any biomechanics there? Do you use, whether you use plaque analysis of the plaque morphology, or is it all kind of AI-based based on, outcomes?
Yeah, so both happen, but what happens primarily is that all the material properties, the tissue stiffness, individualized, is embedded in the model, and then you let AI, you let the computer essentially tailor the right therapy, the right sizing, the right length, the right approach for each individual. And it can run, because of the computer power, multiple scenarios very quickly and recommend what would fit best for this particular wall stiffness, this particular material, this particular anatomy.
So you use a combination
Yes.
of the biomechanics,
And
but
the AI that runs
also
scenarios.
a lot
Yes.
of data where you have
Yes.
pre and post, and
Yes.
you see what variables, what sort of lesion prep results in the optimal. So it's a combination of biomechanics and AI.
Yeah,
Congratulations.
exactly.
Yeah, very exciting.
Great. Thank you very much indeed. So next speaker will be Erik Rafflenbeul. Welcome.
Thank you for having me. Welcome to Frankfurt, to Germany. I'm from Hamburg. My name is Erik Rafflenbeul. I'm an intervention cardiologist. So it's a pleasure to sum it up before you hear the data on EBC DCB on how advancing bifurcation PCI with integrating physiology assessment with pressure wires and using drug-eluting balloons for precision outcomes. So these are my conflicts. The session key learning objectives are that I will show you, hopefully, how coronary physiology can be integrated in bifurcation PCI approaches in high bleeding risk patients using an optowire. Doing then precision PCI, integrating this physiology data and data coming from intravascular imaging and making decision-making in bifurcation PCI, and showing and discussing with you and the panel and the chairpersons to discuss the benefits of DEBs for bifurcation PCI. So this is the history of a patient I met in June this year, a 73-year-old male patient having thyroid carcinoma and myelodysplastic syndrome with low platelets of 31 to 38 per nanoliter. He got hemothyroidectomy, and after surgery he complained about unstable chest pain. When we ask him, he has chest pain CCS class 3 over 6 months. On EKG, had a new diagnosed, had never EKG before, not before the surgery, a left bundle branch block and an LVEF of 33%, so he had HFrEF. He was brought to the cath lab, and this is the anatomy. You can look at it. Everything TIMI 3, but if you look at this LAD-D1 bifurcation, there's an intermediate stenosis. There's only one diagonal branch, giving two branches of this D1, and there's an intermediate lesion. The colleagues decided to defer the patient for PCI because of low platelets. He was then on the table chest pain free, had no elevated troponin, and he was discharged from the colleagues from surgery. After 3 months, he was readmitted to the hospital because he had a resection status of a carcinoma of R1, and the decision was made by the colleagues from surgery of full thyroidectomy. And when we met him, because we knowing he had a lesion in LAD and D1, he complained about more chest pain and his comfort of life was reduced. So we did an informed consent of the patient that we will do a coronary angiogram, and we will do now physiology assessment of this intermediate lesion. And this is how the angiography looks like. It's running a little bit slow. It's not TIMI1 flow, trust me. But you can see here with the guiding catheter inserted that there is still a diffuse lesion before the D1 taking off and after the D1 diffuse lesion. So what we did, when the slides advance, I will show you what we did. Can you go one slide up? It's not advancing. I broke the PowerPoint presentation, sorry for this. So it's about this lesion, and if the technicians can help, then we get the next slide.
Sorry, just a computer program. We resolved it.
It's 5 gigabytes. No, it's not, but okay. So to sum up, we have an intermediate. Okay, now starting. Okay. What we did a physiology assessment with the optowire by Hemonetics, the newest version, and what we measured is a DPR, a diastolic non-hyperemic index of the D1, and you can see on the left panel the position we started, and we measured the DPR is 0.92, so it's over the threshold of 0.89, and we did a pullback. The pullback, there you can see the start of the pullback has even a higher value of 0.94. So, and there was a little bit of a slip coming to 1 before this bifurcation. When we did a physiology assessment of the LAD, we have a pathological value of 0.86 in the distal LAD. It's marked with an A. And in pullback, you can see 2 slight jumps. The biggest jump is B at the level of the bifurcation, and then normalizing up to C in front of this diffuse disease in the mid-LAD. So the precision PCI strategy on the table was to discuss that it's possible to do PCI on the table. We discussed with the surgeons, and they said it's elective. We can wait for another 4 weeks, and we decided to do precision PCI, doing also intracoronary imaging. The plan was to do lesion preparation and then provisional PCI with a DAB strategy of the LAD. And then afterwards, we do post-assessment of physiology and, of course, IVUS. I will now show you, you see the opto wire. This is the wire we put and measured the pathological value in the LAD. It's quite fine. I will show you on the last slide how it works. It's plug and play. It's like a BMW wire. You can work on it easily. And we put a Xeon Blue in the D1 to save it. And I will now show you the SyncVision pullback coming from the LAD. You see this diffuse lesion, plug burden. Now it's becoming a little more plug burden. And here, extensive plug burden. And you see here calcification. What you can't see on the angiogram, you see it now on IVUS. And you see a very big vessel, LAD, coming back to the left main with a good lumen. So the decision, I show you the landing zones, what was defined as distal landing zone. You can see how severe disease the vessel is distal to the bifurcation. And of course, at the level, you can see at 5 o'clock at the level of the bifurcation where the wire is coming in, you see 270 degrees of calcium. The proximal landing zone has a plug burden about 40%, so feasible for PCI. So the decision was made on this integration of physiology and image-based imaging to do a one-on-one lesion preparation with an NC balloon at slightly 12 atmospheres, and you can see in the SyncVision that the balloon has good apposition. Also, at the level of the bifurcation, the balloon is well expanding in the angiogram, and you see the results after PTCA with an NC balloon. I go back. It's not running. Can you show the last picture? The last slide, the right one, maybe? Sorry about this. The right one? The video? Yeah. Oh, a lot of lag time. Okay. Okay. The angiographic result was quite reasonable, so the decision was made as planned before to put a DCB. The lesion length was about 38 millimeters in the SyncVision, so the decision was made to go on one-on-one and not to overstretch it with a paclitaxel-eluting drug-coated balloon, Boston Scientific agent, 4.0 by 30 and 4.0 by 12 millimeters. You can see here also well expanding. And this is the final result. You can see there is a little bit of an impingement of the D1, and you can see a dissection if you look that there is a dissection, but no flow limiting. The PCI was done with 80 milliliters of contrast, so low contrast because it's image guided, and you have to finish an image guided case with imaging. You can see the proximal landing zone. You don't have dissections there. You have a good luminal gain. The distal landing zone, no distal dissection in this diseased vessel. And at the level of the bifurcation, remember it was 270 degrees of calcium. You have good lumen gain, but you have a little bit of a dissection. You can see it here. It's 45 degrees of a dissection. As Bruno Scheller said, you have to create dissections if you do DCB. So there is a dissection, of course. You can see it in angio, but it was not flow limiting. So what we did it IVUS guided but we have this wire on the shelf, and we did a physiology assessment, and we can see that the physiology assessment that the non-hyperemic index improved from 0.86 to 0.95, and of course, if you have it on the shelf, you also, because now you have a little bit of a pinch D1, the value is quite stable at 0.93. So I can sum up. This is what the OptoWire is about. The key benefit of the OptoWire, in my honest opinion, is that it's fiber optic, that it's stable, has good support, is good talkability, that you have the freedom to plug and play, that you can work on the wire, and it's very accurate. You have little drift or no drift, and you can work on it, and after the PCI you can do the pullback, and you'll end up at 1.0. and you're done. So I can sum up in my precision PCI summary is that precision PCI, taking into account that you have to go radial, do it low contrast, integrate intravascular imaging and physiology is key to treat our bifurcation patients. So thumbs up for Snuffbox. DEB PCI is feasible option for patients with oncology disease and for people with high bleeding risk. And last not least, physiology assessment pre and post PCI is key for precision outcomes. Thank you.
Thank you very much. Great talk. I was invited last week at the German autumn meeting in Hamburg to give a talk on DCB, and we had also live in the box case on the Novo disease. And we were told that if you see such dissection in a major artery, the guidelines clearly say you have to stent it. What is your answer to this?
So I don't think so that we have to stent. We have data coming from the area from Eun-Seok, where we had a lot of dissections and the dissections heal. And this minor dissection, which is a type B, type 2 dissection, with no flow limitation doesn't push me to put a stent inside, because the main approach of me was not to put a stent in this patient, because after 2 weeks on dual antiplatelet therapy, he's able to get surgery after getting rid of the clopidogrel. So I follow your approach. I know your approach on this. If you have no major dissection, not medial dissection, then you can leave it as it is.
Okay. Further questions? No more questions from the
So
audience?
Star Wars is kicking me out.
With the patient, it's very good case, very good presentation of physiology and imaging, and also very tricky to treatment the patient with a low level of platelets. But it's a cancer patient, and what's going on? Patient is waiting for surgery.
Yeah, patient is getting surgery on Monday, and I can report maybe next year on social media how it worked. So, so the patient, this case is 2.5 weeks ago. The patient get rid of clopidogrel for 5 to 7 days, and then is getting surgery. He had stable platelets. But we know cardio-oncologist patients are worse treated, like females are undertreated, and patients with carcinoma and are undertreated everywhere around the world. So this is what the decision was made in the first index procedure 3 months before, to do nothing, leave nothing behind, but you could at least say do physiology and see if patient needs treatment, or you can put in on medical optimal medical therapy, which he was on. He had HFrEF, he was on bisoprolol 10 milligrams and all other things, Magic 4, and still having chest pain.
One short question from the audience.
Yeah, it's really the general question. How did you decide on 2 weeks of antiplatelet therapy with that dissection?
I think there's data on it for DCBs to do it for 2 weeks. The general recommendation is for cardiologists, oncologists, patients coming from SKY, which is from 2016, to put a BMS and put the patient on DAPT for 4 weeks. I haven't used a BMS since 9 years. So it's a little bit, it's not evidence-based medicine, to let you know. It's eminence-based, but I think it's feasible to do it to give time to the lesion to heal, and I think 2 weeks are enough.
Okay, and I have a question, and I think in your case, and you are lucky because you choose the very big size free balloon, so 4.0 millimeters. So in the era of balloon angioplasty, and usually the balloon to vessel size is over 1.3 ratio, and it can be easily developed severe dissection.
Yeah.
And flow limiting dissection, I mean. So I'd like to know what is your Vera stenting rate in your...
The reference diameter distal in the LAD was 4.3, and proximal to the bifurcation was about 5. So the DCB just touched, but the aim was to treat the lesion at the level of the bifurcation, distal to the bifurcation. You can see, you can use the smaller DCB and touch nothing, but my decision making on having an IVUS eye, maybe on angiography, is choosing for a little bit undersized, not 1-on-1, but it's 1.9 maybe. Yeah, but the risk of dissection is even greater when you use big balloons and NC balloons.
Great. Thank you so much.
Thank you.
We are a little bit running out of time. Now comes the long-awaited final talk by David on the planned new trial.
All right, this is tricky. It says looking for sources. That's not very encouraging, is it? Here we go. Okay, excellent. Thank you. Right, EBC DCB. I managed to say it without tripping up. That's good. Briefly, the background to this. Okay, so nearly all my career I've spent trying to work out how you should stent the LAD diagonal territory, because it's always LAD diagonal. That's at least 80% of the cases. That's where all the interest in bifurcations came from, right from the Nordic 1 trial. And actually, let's put it a different way to how I've written here. If somebody now came to you with a thing and said, oh, we've got this great new technology for coronary arteries called a stent, we're going to apply it to bifurcations, you'd think, oh, that's not very good, is it? So it's a single cylindrical metal tube that you put down. Well, you only do one limb or the other. So then what do you do? And you go, yeah, what you do then is you mangle it, and you expand it, and then you cross it with the wire, balloon the side, malapose it, and then push it back together. And then you think, no, it's all right. I'm going to stick with my balloon therapy, if you don't mind. So, that's the other way round of looking at this, is that, we have spent ages and ages trying to refine how we should do this, with, how we approach the procedure. And actually, it's still slightly messy, because, as we have increasingly been discussing over the last few years, there are nagging doubts about this. One is the clinical experience of it. We continue to see drip, drip, drip of late acute or acute on chronic stent occlusions, which we were not expecting. We originally thought, oh, it was all Taxus with that horrible polymer, and it's all the fault of that, and it doesn't apply to modern stents. It doesn't apply now we do imaging and stuff like that. But I don't really buy that. The attrition, show me a study where we haven't got that kind of 1 to 2% annual attrition rate with stenting. And that's related to, lots of different factors, but it can make further treatment very difficult. You can't take that stent out once it's in there. Permanent metal implant, it's an inflammatory nidus, however you look at it. It has some disadvantages and permanent antiplatelet issues. So, against that backdrop, and against, I'm rather delighted to say, some abreaction from colleagues across the large pond who've taken shock that this has been suggested as a trial. We're all going to do a randomized trial of stepwise provisional stenting versus drug-coated balloon therapy for non-left main stem true coronary bifurcation studies. And hats off actually to Medtronic for deciding after, ordinary preamble to back the format of this study, which was very much not, oh, let's just do the side branch and see if it's okay. No, we're going to do the whole thing with drug-coated balloons. So it's got all the governance that you'd expect of a big study. CERC will be the research organisation, have steering committee, DSMB, CEC, all of that kind of stuff, a core lab. It'll be a 750 patient study, one-to-one randomization of DCB against DES. It'll be the Medtronic platforms. There'll be 6 to 8 countries. Now, here comes the fun bit, 20 sites. So, countries that are already in the bag, because they've paid me lots of money, are the UK, Germany, Italy, and France. Now, if you are from a different country and you'd like to be in this study, I will be available in the foyer afterwards. Okay, so the hypothesis of the study is that drug-coated balloon therapy is non-inferior to provisional drug-eluting stent implantation for non-left main stem true bifurcation lesions, and the objective is similar to look at the stepwise drug-coated balloon strategy versus the stepwise provisional drug-eluting stent strategy. How's this going to be done? Okay, so I'll come to some of the inclusion criteria in a minute, but it's going to be one-to-one randomization with the primary endpoint of a 1 year. It's a bit of a mouthful, this bifurcation-orientated composite endpoint of cardiovascular death, target bifurcation-related MI, and target revascularization. Okay, so not much argument probably around that. We'll have secondary endpoints, and very deliberately it's out to a long time scale because, it may be that it takes a little while for the benefits really to become apparent, and that's why I think it's taken us, I should say me, but it's taken us so long, I think, to realize what the disadvantages of stenting are. So it'll have out to 8 years endpoints. These are all the secondary endpoints. You don't really want to hear about those at this stage. So inclusion criteria. This is a little bit indigestible, I'm afraid, but bear with me. True non-left main stem bifurcation disease. Medina categories as you would expect. Bifurcation lesion being responsible, so that you must meet both these criteria. Responsible for an acute or chronic coronary syndrome with at least one of the following. The print starts to get a bit smaller, I'm afraid. Greater than 70% angiographic main or side branch diameter stenosis. Either positive non-invasive testing for ischemia or positive coronary physiology or imaging for ischemia. And then a significant side branch diameter stenosis, and building on the work of Bon Kon-Ku, who I hope is here, maybe not. Side branch length 73 millimeters. Side branch diameter greater than 2.5 with no more than one other side branch. So this is the kind of single diagonal phenomenon. Or similarly, a largish diagonal that has nothing further downstream of it, or one that has a non-dominant circumflex artery. So I'm sorry, it's a little bit complicated, but it basically means anything that you look at that thinks, oh, that's an important side branch, probably will fit in the study criteria. The exclusions are the standard stuff about STEMI and cardiogenic shock and really, really terrible left ventricular function. You can do other lesions, of course. It's not that common to find an isolated bifurcation lesion, but you can't do more than 2 others because otherwise we'll get too much noise, and those should be treated with the same technology. Here's just the list of the exclusions that we're expecting. Here is the trial schema. It's a little small on this page, so I've cut it into 2 bits. And as was discussed earlier, the randomization is going to be up front to avoid people perhaps doing timid predilatation and then allowing the patient into the study. So the randomization is completely up front. The stepwise strategy, I think we're all pretty familiar with, so we won't go through that too much. The drug-coated balloon strategy we will go through a little bit in a second. I'll skip this because I'm going to talk about it in this little bit and we're short of time. So the important concepts, I think, for this study are, okay, provisional stenting, straightforward. We've all been talking about it for years. We know the drill. It's exactly as written on the tin. For the drug-coated balloon strategy, and you know, it's taken us a while to learn from all the people on the panel here who've been doing this for years. The basic strategy is wire both vessels, one-to-one predilatation and preparation of the main vessel first, and that will probably mean more liberal use of cutting balloons, scoring balloons, things like that, than previously we've been used to with just stenting. Then, if acceptable, and I'm going to come back to what that word means, then one-to-one predilatation and preparation of the side vessel, DCB to side vessel, DCB to main vessel. So it's main, side, side, main. What is the meaning of acceptable? And this is where people will develop their own expertise over time, but for the protocol, acceptable in terms of predilatation and preparation means that you shouldn't have more than 30% recoil of your lesion post-preparation. That either means that it's too fibrotic and you're not going to get good dilatation of it, or that you probably, in 90% of cases, actually need to do some more to make sure that you get to fully expand it before you consider putting a drug on the wall. TIMI3 flow, obviously very important. You're not going to end up leaving something that has less than TIMI3 flow. And then in terms of the dissection, I think it takes a while for people to learn what is acceptable to leave, what is not. So and the exact wording is still being negotiated, but no dye hold up at and around the treated lesion. So the old category, the sort of type A to type H, you know, nobody can remember what those categories are. And so we all sort of say, well, if we say B or C, that sounds about right. But nobody remembers what they are. So let's forget that. Say no dye hold up at and around the treated lesion. No dissection that's actually propagating beyond the treated territory. Because that means, okay, can keep going, but you need to secure it with a stent. Sorry, I'll just go back to that. So those are probably at this stage at least, and the guys will be able to tell us, you know, is this what they see as the correct definitions? And then all follow-up after that is clinical. It's outcomes based on numbers, really. So do the patients do well? Do they get any recurrent angina? Do they come back with hard clinical events? And the follow-up strategy, sorry, this is a repeated slide. The follow-up strategy basically is clinical from interviews at 6 months, 12 months, 3 years, 5 years, 8 years. So with that study, we should ideally, I think, have, you know, a really large group of patients that we can work out over time. Do we get at least non-inferiority using drug-coated balloons compared to stents? Because from my point of view, if we get non-inferiority, then the drug-coated balloon is by miles a winner because it has lots of ancillary benefits to not having that permanent metal implant in your arteries. Okay. That's the end of my presentation. Open for discussion. Thank you.
Great. I think very provocative design, but we are happy to do this. So I think we have many questions from the audience.
Okay. Sorry, I didn't get it. In the provisional stenting, you stent the main branch and you go through all the steps. In the side branch, is it just a normal balloon or do you put a DEB in the side branch?
No, normal.
Okay. But if the trend nowadays is going towards DEB, should we not be putting a DEB? Because you're almost setting yourself up for another study, because if the restenosis is in the side branch, we're going to say, well, a DEB would do better.
No, other people can do that study. I mean, we've done loads of studies. We've done loads of studies with kissing balloons into the origin of the side branch, and the noise rate is surprisingly low.
Patrick?
David.
Yes.
Here, David. Here,
yes,
here.
Patrick.
No, I think that it's very ambitious, and it's good to be ambitious. And the long-term follow-up, that's what I've learned, is the most important things. At the end of the days, we are planning now something again with the surgeon. It's the qualities which is important. I'm alive, and I'm happy.
Yes.
And I can play golf or whatever. That's what is important. So that you go 1 or 2 times on the table because you have to redo that DCB, it's a good thing. We should forget this revascularization as a definitive, dramatic event. No, you can work on the coronary for a long time. So I like that very much, the long term. I like also very much all the pragmatic aspect. I think at some point you will be able to quantify one technique of the others, the myocardium at risk, and not go for the things which is pitiful and small and not useful for the patient, not useful for the prognostic. There is one thing I disagree, is the use of the word provisional. I'll tell you a story. I introduced that word in 1989.
Yes.
And initially in my abstract it was conditional stenting. And I didn't like the word conditional. So I went to the Webster and I found the word provisional.
Yes.
Said, it sounds good, it sounds British. Okay?
Yes.
So I use the word provisional. But it's not the stent which is provisional, it's the drug-coating balloon which is provisional.
Yes.
Because if you go to the Webster, a provisional government is something which is not stable and will disappear. So all these years, I introduced the wrong word for provisional stenting.
No,
stenting is definitive, as you said, it's a piece of metal who would stay forever. What is provisional, transient, is the attempt of the drug-coating balloon. And recently, we were again not correct, because I correct in advance, by the Lancet, who said that word should not be used as provisional stenting.
Yes.
It's definitive stenting and provisional drug-coating balloon.
Yes, I completely agree with you, actually. But when it first came out, I was much too junior to raise my head and say that's the wrong word. I completely agree. I assumed it was Thierry Lefebvre, but now I know it's you. I can argue with you later.
Yeah, I mean, I'm not British, so you have to excuse me that I use that word that I found on the Webster, but I used in the wrong way.
We'll look for a new
For
word.
35 years.
Yeah.
David, great design.
Sorry.
A great design. I have 2 questions for you. One is, why do you go for the non-inferior design and not a superior design?
Yes.
Because you say there are a lot of auxiliary things or advantages of using DCB, but one is not, and that is the cost, because that's considerably higher with the DCB than it is with the DES.
Oh, sure. But eventually, once we're all using DCBs, the price will come down. The Cypher stent used to be $1,500, dollars. It's actually designed to be non-inferiority, and if that's met, then superiority is tested. So I think it satisfies both, I hope. Yes, question, sorry. Yeah, I think that muddies the water. We've seen from some of the studies from Xiaoliang Chen's group that sometimes when you have angiographic follow-up, you then have event rates based on the oculostenotic reflex. DK Crush 2 and 5 both suffered from that. So we really wanted to say, no, let's do a trial which is sufficient numbers that the clinical endpoints as they come along will define the result of the trial.
What about lesion length on side branch? I mean, is it unlimited or?
Okay. So we haven't put an exclusion in there, and it depends a bit. I mean, maybe some people, when faced with a 20-millimeter lesion in the side branch, will sort of think, oh, I don't want to put that one in the study because it maybe needs a stent. But by the same token, they're going to be treating a long lesion in the LAD and using drug-coated balloons. So we've deliberately excluded that as an exclusion, if you see what I mean, and left it up to people's discretion.
That might be a big difference between short and long lesion anyway on the side branch.
I'm not sure, actually. I mean, if the DCB actually proves to be effective after predilatation, then there's no reason why, just because it's the ostium and origin of a side branch, would be any different to the main vessel. So I think we'll wait and see with that, but we deliberately left it out because of that.
Second point is about kissing balloon in provisional stenting.
Yes.
It is mandatory, or?
It is mandatory simply because We wanted things to be equal between the two groups. In the DCB group, you're definitely treating the side branch. So in the main vessel group, we have to have equipoise, and it's a 1-1-1 lesion, so it's perfectly reasonable, although not obviously advantageous, to have a kissing inflation.
Yeah, but this might induce some deformation of the stent caused by wrong crossing of the stent, and I think if you do not have need for crossing the stent, I think it's better not to cross the stent.
Sure, I mean, and that's a separate argument, but in the study what we need to have is two groups that are comparable. What we didn't want to do is have diagonal branches that are so small that basically this was just a study of drug-eluting balloons versus stents in a main vessel that happened to have a rather small bifurcation. You know, it has to be important enough that it could have event rates on its own right.
So sizing mandated by intravascular imaging?
No.
Okay,
No.
and then do you have a sense of how much crossover you may have?
10%. It's a bit of a guess, but the guys will be able to say.
I think this is one of the challenges to have the crossover rate to stenting in the DCB group under control. I think that this needs maybe some training of unexperienced sites and clear rules in the protocol. Let's discuss. I think.
What about the APT? Because one of the benefits of DCB is to make the patient less dependent on the APT.
Yes.
Is a part of the benefit of the strategy. There is a difference in documentation?
There is. So there's mandated or stipulated DAPT requirements in the stable and in the acute setting for both the stent group and the DCB group, and obviously it's a bit less for the DCB group. Yeah.
Calcium modification.
Sorry. Yeah, we got it.
Okay, I think we have to close. Great session. Thank you very much.